Good morning, everyone, and welcome to this session. This is a postgraduate course, and for the very first time, we're doing a live transmission from McGill Hospital. And you'll see a lot of interesting cases, and we're very excited to launch this. So I hope you enjoy this session. So without further ado, we have Dr. Moscow, who is at McGill, and he's going to be giving us the first very brief talk about endoscopic technique for polypectomy, hot versus cold snare. Most of you probably know Dr. Moscow. He's one of my colleagues. He's a great colleague. He's a therapeutic endoscopist at St. Mike's, and he has very niche expertise in polypectomy, ESD, particularly now, and also pancreatic biliary endoscopy. So welcome, Jeff. We're here and we're seeing your presentation.
Great. Hopefully you can see my slides, but maybe not me. Yenny put me in some closet here at McGill. It's the only quiet place here. But anyways, it's a real pleasure. Thanks for the introduction. Hi, everyone. We're really excited about this morning. And so let's rock and roll. We're on a tight schedule. So I'm going to talk about your choice of polypectomy technique, hot versus cold. What makes this challenging? Well, the data has been oscillating over time. We sort of have improved outcomes across the board, specifically with hot EMR. Our toolbox has expanded, but overall, I think, the spread of techniques is still pretty slow in endoscopy, and I still get questions when I speak about techniques that we were talking about 10 years ago. We overall have a lack of optical diagnosis expertise, and there's lots of external pressures that affect our decision making. And so if you haven't seen this update from the ESGE, I highly recommend it. It really gives a nice approach to how to tackle lesions and some of the things that I'm going to be talking about today. And really, this isn't just a do I do it hot or do I do it cold discussion. The discussion is bigger because EMR is now a toolbox, and we need to really be well versed in all of the options at our disposal, both EMR techniques, conventional, under saline, cold snare, cold EMR, and really adjunctive techniques as well. So, the US consensus guidelines, which is now a few years old, for lesions in the 10 to 20 range, and we're going to be focused on lesions 10 and above today, that don't require en-bloc resection. The US consensus says you can take it off hot, you can take it off cold, with or without submucosal injection. But the question is it really that simple? Can you just do whatever you want? So we have to think about what these techniques really mean. And so endoscopic mucosal resection implies injection and removing something with electrocautery. It's effective, it's available. We know our experience now is over many years. It is less morbid and less costly than surgery. And this data out of Australia and Michael Burke's group clearly shows that the recurrence rate for EMR with thermal ablation of the margin has gone down to extremely low. So this is an effective technique. However, in the hands of mere mortals like Steve and Eric and myself, we have problems with incomplete resection, recurrence, perforation, and bleeding. And so now, probably 5 years ago, the cold revolution started, where we talked about cold snare endoscopic resection of non-pedunculated polyps. And the initial data, and this is out of Alessandro Rapici's group, showed that this is an extremely safe technique with high rates of complete resection. And so, the thought was that you can save time, save money, and really it's safer for patients. And so you can see in the top right, we're injecting, I inject saline, methylene blue, and dilute epinephrine. The methylene blue allows you to get some chromoendoscopy and look at the borders, and you're really just avulsing tissue off with a dedicated cold snare, and allows you to remove these polyps quickly and very safely. And so you can very easily, within minutes, take these polyps off, and the margins you can see here are very clear. So we know when there's residual or not. Extremely quick, extremely easy, and safe. And so what has the data shown over time? This is Mohammed Bilal's a systematic review and meta-analysis, which show very high rates of technical success. But the data that's coming back is showing that the recurrence rate for adenomas seems to be significantly higher than sessile serrated lesions. And so the question is, well, where is this technique best? It seems best for maybe smaller polyps and serrated lesions. But do we have head-to-head data? This is a prospective randomized trial out of China, 700 polyps in the 6 to 20 range, where they compare cold snare versus cold snare EMR versus EMR. And they found that complete resection rates were higher with any injection technique, so both cold snare EMR and hot EMR. Intraprocedural bleeding was higher in the cold snare polypectomy group only, so the ones with no injection, and delayed bleeding, no surprise, was higher in the EMR group. And so their conclusion was that cold snare EMR is both safe and effective. This is hot off the press, another meta-analysis comparing the techniques, 7 randomized controlled trials with over 1,000 lesions in both cold and hot, and they found that cold EMR was associated with a much higher rate of recurrent neoplasia. So again, this is the message that I want you to take away, with lower rates of delayed bleeding, again, because of the lack of electrocautery, and lower rates of perforation. So there's a next to 0% risk of perforation with this cold technique. But they had similar rates of incomplete resection and intraprocedural bleeding. So the question is, can we best identify lesions suitable for cold EMR? And I believe that we can. And so this is data looking at just sessile serrated polyps greater than 10 millimeters, and the pooled residual rate for cold EMR was similar to hot EMR, and they had really much higher delayed bleeding in the hot EMR rates. So we're showing that the RRA for sessile serrated lesions seem to be acceptable and maybe similar in the cold versus hot group. So what's my current approach? Well, of course, you're going to be seeing today us meticulously examining lesions, and I think that still needs to be your first order of business, and try to predict the histology. In this lesion, there's clearly an abnormality in the center of the lesion with the depression, even though it's small. And so this is the lesion that needs to come out en bloc. And so I'm choosing a technique that's uses electrocautery and gets this out in one piece. I always try and predict the histology, as I said. And if the lesion is a sessile serrated lesion, I'm injecting and I'm taking it off cold. If it's a tubular adenoma like the one you're seeing now, then I'm considering my options. If the patient is on anticoagulation and has not come off, then I'm doing a cold technique. But almost always I'm using EMR with thermal ablation, which you're going to see in the bottom right. If it's a 1S lesion or there's any bit of bulk to it, and I know that my cold snare is going to get stalled, then I'm using hot snare EMR. What about lesions greater than 20 millimeters not requiring en bloc resection? Well, the recommendations from the US consensus is just hot snare with thermal ablation. This is a trial out of Germany, the Chronicle trial, also very recent, multi-center RCT of 19 centers, and they did a 1-to-1 randomization, 396 lesions greater than 20 millimeters, and they excluded lesions that were too large for cold snare. And they found that they had to convert actually 7% of their cold snares to hot snares. And as expected, the adverse events in the cold snare group significantly lower, less perforation, less delayed bleeding. And they had very high residual neoplasia in their cold snare group, almost double. But when they separated adenomas versus sessile serrated lesions, they found that the residual was not different. And their residual neoplasia in the LSTG mixed lesions, again, was upwards of 44%, almost a coin flip. And so that's just totally unacceptable in my opinion. And then this trial, which was just accepted out of Spain, where they took 25 experts and 229 lesions, mostly adenomas, they had to stop this trial early because the residual and recurrent adenoma rate in the cold snare EMR group was just too high. So I think, while this cold revolution was really exciting at the beginning, this is not for all comers. And so I think the way to approach this is that if you can tell that it's an adenoma and there's any bulk to this lesion, you absolutely have to use heat. And so that's what I do. I look at the lesion and I carefully examine it. This lesion on the right is appropriate for EMR. There was absolutely no features of submucosally invasive cancer. And so this undergoes hot EMR. I'll do hybrid EMR if it's needs en bloc resection 20 to 25 millimeters, and greater than 25 millimeters lesions get ESD. If it's an SSL without dysplasia, then I do cold snare EMR, which you're going to see in the bottom right, regardless of size. And so the lesions 8, 10, 12 centimeters can all be removed cold. This is very fast, this is very quick. Any tubular adenoma gets EMR with thermal ablation of the margins. And again, I will consider cold snare EMR if they have not stopped their anticoagulation, or for whatever reason we need to be very, very risk averse. So I think the consensus now is we do cold for SSLs and hot for EMRs, and we're going to be demonstrating both of those today. So thank you very much for your time, and looking forward to an exciting morning. Thanks, guys.
Sounds
Thank
good.
you.
We'll see ya.
GI fellow, Miguel.
Keep rolling.
I'm presenting a case of a 77-year-old patient who had a positive fit test and a colonoscopy in November 2024. Multiple polyps were resected except for one in the proximal transverse colon that was 2 centimeter laterally spread with a pseudodepression. The area was marked with a tattoo, and biopsies were obtained with the path showing tuberculous adenoma.
Awesome. Well, thanks so much for the thorough history. So, hi everyone. Pleasure to be here at the Glen site in Montreal. And McGill, congrats to Yenny and the team here. I'm here with Talat. Fortunately, there's someone to keep an eye on me, and most importantly with Norma, who has already been really nice and welcoming. So she clearly hasn't talked to my nurses back home about me. So yeah, we're here, and so I can show you here, we're in the right colons, and so we did water immersion to get here to try and minimize leak formation. There's the ileocecal valve, and this is the lesion that they found. And we actually had already rolled the patient, and I'll explain why we did that. You know, obviously, whenever you find a lesion, the first thing you need to do is a thorough assessment. And so Talat and I have been kind of looking at this a little bit and pondering kind of our decisions about life and why we chose to come into therapeutic endoscopy. And so, you know, looking at this lesion, and the first thing that Talat said was, do you think there's a central depression here? And I said, well, it sort of looks depressed, and but you know, on closer inspection, and so I'm going to come in a little bit closer. So I'm using MBI here and near focus magnification and a little bit of water. And so when you examine this and the water adds magnification, I saw Rob doing a really thorough exam of his lesion. And when you try to get this underwater, maybe we'll be able to. I think that what you see is that that center part it does not have too much of an alteration in the pip pattern. It actually just looks like JNET 2B and tubulobillus adenoma pattern to me. So I actually think this is a pseudo depression and not a true depression. Natalia and I talk about this back home all the time. And so I think this lesion is still appropriate for EMR and piecemeal EMR. The other thing that we think about is we use gross morphology. And so Talat, what do you think about the gross morphology of this lesion?
Yeah, so as you described, so basically it's, first of all, we look at, so this is a laterally spreading lesion. It's a granular type with that central depression that you mentioned. But that looks like probably a pseudo depression. I guess it's going to help us also when we start the process of lifting. I think that's going to be very helpful, seeing how the polyp reacts as well.
Yeah, so I guess what I was getting at was we used the Paris classification and granularity. You mentioned that this is the granular lesion and Paris classification. So this is predominantly 1S lesion. There might be some 2A component, but it's predominantly 1S. And so when you combine those things using ACE cohort data, we know that the risk of submucosal invasive cancer in a lesion like this is very low, less than 5%. Maybe even lower than that. When you look at LSTG homogeneous lesions in this location, they're going to be really low. And so again, that makes hot EMR appropriate for this lesion. And so I see Steve Hypen's brain wheels turning on the panel, and he's saying, well, maybe none of this matters. You could just take this lesion en bloc. But I think this is borderline too big for that. I think once you inject this lesion, you're going to have to put your biggest snare around it. And in this location, I think that increases your risk of perforation, even if you're as good at injecting as Steve is. And so I think that you're not losing a lot by doing piecemeal EMR with thermal ablation to the margin for a lesion like this. And I think the chance of having cancer here is really, really low. I know Jeremy would do this by ESD, but in my unit and the way we're going to do it today is hot EMR. The only other things to consider here are gravity. And so I am, as you notice, I am underwater here. So we rolled this patient's right now in left lateral decubitus position. We rolled the patient to supine and then to right lateral. I always like the anti-gravity, and that's just in case there's bleeding. You're not under a pool of blood, which we will be here, and the polyps. But when we roll the patient to supine and to the right, we no longer had access to this lesion. So difficult colon, I know because I have done the colon now, and difficult access. So the only place that we have access to this lesion is left lateral, so we're sacrificing gravity here. There's also a tattoo approaching and right underneath this lesion. So I'm not going to ask who did that, but in general, I don't love when tattoos are underneath the lesion. I don't believe that this lesion even needed a tattoo to lat because we're bringing this back endoscopically. So the only time you need to put a tattoo is when you're marking it for either when the lesion is really subtle and you're not going to be able to find it, which is clearly not the case here, or when you're marking it for a surgeon that needs to go to the OR. So I think this lesion did not need a tattoo, and we'll see if it gets in the way. So we were talking about how to approach lesions like this, and my approach is to start on the anal side and work my way oral. And the reason I do that is a few things. Number one, it's the easiest for me to access. And number two is I'm able to see the edge of my snare. And so when you can see the edge of your snare, you know you have normal tissue. And so you know that your margin is going to be clear. And so again, the goal here is to leave no cells behind. And when we use that approach margin to margin, we're able to be as sure as we can that we're not leaving anything behind. The only other thing that I wanted to show everyone is that I'm using a 1100 colonoscope with the EVIS X1 series from Olympus, and I think it's an amazing innovation for two reasons. Number one is the X1 platform has really changed my practice. We're using TXI 1 right now, which is texture and color enhancement. And I'm going to toggle it for you. I think I'm going to toggle it for you. I'm going to toggle it for you in and out just to show you. So here is the old view that you're used to. Even though the optics here are a little bit better with the 1100 series versus the old 190s. And then we turn on TXI mode, and it really, these lesions jump out at you. And so when the texture and the color is enhanced, even with the 190 series, because this is all post-image processing, are coming from the processor, the images are just way better. And we could talk all day about that. I'm also, the scope here is 10% lighter and has ergo grip, and so I'm really liking the feel of the 1100 series. Okay, back to work. And so we've taken this first piece, it went really well. There's a little bit of oozing coming from underneath this area. I'm ignoring that now, and I'm going to treat it later. And so I've injected only the front, and so we're going to take a second piece here, open. And so again, the fact that I'm underwater makes this a little bit more challenging. I'm laying my snare here on the left to ensure that I have a normal margin, and I'm slowly working my way to plant the other part of the snare into the EMR defect that I created. Close just a tiny bit. Stop. And so you want to open a tiny bit more. And so you want to have your snare open enough that you can control it and you can see where it's going. So I wasn't so
yes, Steve here from the audience.
So I'm going to work a little bit harder to make sure. So I'm happier with that. You can see what's going on the right side. I use near focus. I push my snare out, push my scope in. I'm going to suck air out of the lumen. Now close, please. Close, 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 close. Good.
Jeff, can you tell us what snare?
Norma's really good at this, fortunately. And now I'm going to go through it using Endocut Q. And so that's a nice piece. Let's see what we did. Okay, and so Talat thought I was going to leave a bridge there, but fortunately I didn't. And so I'm looking into the defect here. So that looks pretty nice, no DMI. Let's take this out, please. And so now we're going to inject the rest of the lesion. So some people inject the entire lesion at once. I usually like to inject, we're using saline here, so I inject an area, work on it, and then inject a little bit more. So I'll take injector back, please.
So you use the end of the first resection as your margin, really, to help you anchor your snare to get better.
Yeah, so a lot of people say always start at the hardest part. I usually start at the easiest part, and once I have a plane into the submucosa, I'm better able to continue my resection. So again, everyone has different approaches, but that's what works for me. And so here we're going to leave the needle in. And so you don't have to put the needle out to inject into your EMR defect. So inject here.
Jeff, could you just, also, it's Steve here from the audience.
You can see that lifts up even without the needle in, just another technique that you can use. And so now I'm going to try and come behind the lesion to see if I can inject there. Access to the back is not great. So I'm going to use the catheter and push the fold down if I can. Needle out. Inject. Go. Nice job. Look at that back is going to be injected now.
Your needle, yeah. I think one thing that is also very helpful, Jeff, if you agree, is to use where you inject it to find the space already. So you can put your needle already in there.
Yeah, needle out. Inject. Go. So you can see it lifting even though I didn't know exactly where it was, and you can keep going, go, stop. All right, so we have a nice injection there, so I'll take the snare back.
Jeff, there's a question from the crowd. We're wondering about the snare size that you're using.
Yeah, so we talked about that too. I like 15 or 20. I'm using the Olympus Snare Master, not the Snare Master Plus. I like this snare. It's medium stiffness. It opens up to 15, and I find that I have excellent control. I also like the Captivator 220, a little bit stiffer. I don't like using more than 20 because I find that you're increasing your risk of perforation by grabbing the muscle. I think a 15 snare is totally reasonable for this. 20 if you want to be a little bit more efficient. Open the snare here, please. Steve, what would you use for this? Close a little bit. Stop.
Yeah, I would similarly use the snare.
He says he agrees. Close.
I wouldn't go larger than 15, personally, on the right side.
This may be a question, Jeff, also when
You
you're
guys, just hold up for a second. We are having trouble getting questions from the auditorium, so they can't communicate with us for now.
Okay.
I'm going to fix that. So just to let you know, and they're texting me questions for now.
Okay, great.
no problem.
So I'll just keep talking then, Jenny.
Yeah.
It's better that way. Close.
So one question for you, Jeff, is once you've closed your snare, do you pull away from the mucosa a little bit?
Yeah,
Pull it up.
I tend to wait a little bit. I think, we used to do that a lot because we were worried about deep neural injury. I think with the way we're doing EMR now, that's not a really big issue. And so I usually will move the snare open, please. I usually will move the snare around a little bit, mostly to feel if I have any muscle entrapped. And so once I'm pretty confident of that, then I don't think you need to tent away as dramatically as we used to do. And so I'm going to turn on near focus. We're still underwater. And I'm going to push the snare in. I'm going to push the scope in. Close, 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 close. Good. Okay, ready? And cut. Okay. So now I'm going to reassess and see what we have left.
Jeremy is just going to show the polyp and we'll come right back to you.
That was quick. Open. And so we're not as slick or as fast as Jeremy, but we are almost done. And so close, 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 close. And so Talat was asking me about, I only injected the front and then, but not the back. Am I worried that I'm going to capture an area without injection? And the answer is, yeah, I'm always worried. But I think that we're able to, we're going to treat this bleeding. Tip out, please. But that's why I use a 15 snare so I can control it a little bit better. So I'm going to try and suck some of the fluid here before we treat it because we're using water here and not saline. So if you want to do anything, use electric pottery underwater, you absolutely need to be under saline. So to treat these vessels, it's very simple and easy. We're going to use soft coag, effect 480 watts. You just have to check that it's set appropriately. So effect 480 watts. This is the old vial here. So we're just going to use the tip of the snare. So I'm isolating it with the cap. I'm going to take a little bit less. That's perfect. And that's blue pedal. I'm going to just come back so you can see what we're doing. Again, we're fighting the position in the colon here.
I think that's a great demonstration of what you're talking about in terms of gravity at the beginning, right? I mean, if you end up with a bleed,
right?
Then, here it wasn't a big bleed, but
yeah.
If you end up with a big bleed, then...
Sure. Yeah, if this was a pulsating bleed, I would have gone fully underwater, and I would have probably asked for a coag grasper. But something like this, again, pretty easy to treat. And so now I'm going to just make my way and treat a few of the vessels. Now, there's no data to suggest that actually prophylactic treatment of these vessels is useful, but these are oozing, so it's totally different. And so what should we do now, Talat? We think we have all the polyp out. So what would you do at this point?
So I mean, once you've done the treating the bleeding vessels and so on, the next point is edge cautery.
Yeah.
You need to make sure that I think data's clearly shown that reduces risk of although you try as much as possible, you do your exam, make sure that you take it that there's no residual visible.
Yeah, well, I'm examining the margin here to make sure there's no adenoma left. And so I'm pretty happy that I don't think there's any adenoma left. And then I'm going to go to the defection filth. What do you think about that, Talat? That's probably normal.
Yeah, I think that's okay.
I think that's normal too. And then the question is, what's this? Is that actual tissue or not? Is that adenoma? You know what? We can take that off. Can I have that cold snare, please? So we actually, off camera, we took off a little polyp that we found on our withdrawal because if I came all the way to Montreal to do cases, I'm not leaving any polyps behind for this patient. So I'm just going to use a cold snare to snip this off, only because I don't think there's any adenomatous tissue there. But again, I need to be absolutely sure. So I'll treat any residual tissue that I see, even at the risk of making injuring the muscle. Open, please. So I'm going to try and grab this. It's often a vessel. Close, 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 cut. Good. But now we can be pretty sure. We've unroofed this vessel here, which was in that bundle. I learned learned this from John Anderson, who calls it the Anderson sign. He says whenever he tries to take off extra tissue, there's always a vessel underneath. I'll take the snare back. So we're going to treat this vessel, and then we're going to do thermal ablation to the margin, snare tip soft coagulation. Again, from Michael Berg, because his data shows that you can get recurrence down to about 1 to 2% with this technique. We have in-house today Daniel von Rentelen, and he and I have been involved, and he is leading the charge in terms of looking at hybrid APC to treat both base and margin. And I find that really exciting because, again, we need to get our recurrences as close to zero as possible, and lots of exciting data coming out of his center and really across Canada with hybrid APC. So again, I'm using soft coag for this. And then we're going to go around the margin. So the treatment of the margin has evolved over time. We used to just touch it, but now we're okay to really, like, as Michael says, like barbecue the margin there. You want like a nice white rim. And again, his early data showed recurrence in the 5% range. His more recent data, he says he has absolutely no recurrence, and that's probably because he gets a little bit more aggressive at the margin, a little bit more tip out, and then to that, a little bit less, sorry. And then the big question is, do we close this or not?
Yeah.
To close or not to close? What do you think?
Yeah, that's, naturally that's the next step, right? I mean, once you've done your cauteries, of the margins, I think the data is compelling towards, more and more towards, although, closure, especially in the right side. I mean, here there's probably some, reduction in terms of late bleeding when we close.
Yeah, so I think the answer is clear. I think you close these lesions if you can. And so the question is, and the reason you do it is to prevent bleeding, like you said. Posterior mark bleeding is terrible for the patient and also hard on the system. And so, the data is pretty clear now from Heiko Bull study and multiple similar studies that we need to clip these defects close. So the question is how to do that. So do you use standard clips? Do you use fancier things? What do you think?
I think they're different, as you mentioned. There's standard clips. There are other ways to close it. It really depends on the shape also of the defect, right? Because that's some defects are much harder to close just with standard clips because of the size of the defect.
Right. So what do you think? So here's our lesion. Here's what it looks like after snare tip soft coagulation to the margin. So I'm pretty happy with the appearance now. Hopefully Natalia approves. She's a tough critic. But I think it's time to think about closing this. So for me, I don't know how much time we have, Yenny, but I think there's a few options. I think standard clips can absolutely do the job here. And you can start on one side and zipper it forward. There are some newer clips on the market, Mantis and gap clips, which can help oppose mucosa in approximate size when you're talking about very large defects. This is more like horizontal, so I don't think so. And then there's, even newer things like suturing and X-Tac. And so, again, new to Canada, and I think really exciting in terms of closing right side lesions. Suturing not possible in this area because you can't get the device all the way up there, but X-Tac definitely is. And so I think that would be an option here. And so I think why don't we do standard clip closure here, even though I did want to demonstrate X-Tac, but again, I think what I also want to show people is like how to close a defect like this and that it is possible. So what do we have for clips?
Microtech. Yeah.
Okay, sure. Let's start with the bigger one. So Microtech Yellow. This is a 17 millimeter clip. This is the design, like the original. This is the original Microtech clip, so not the Locato design. And so there are Licado clips now available in Canada, which are excellent as well. And so we're going to start on one side and work our way to the other. What do you think?
Yeah, I think, which side would you choose first?
I don't think there's a right or wrong. I think, we know that the clips come out in the 5 o'clock position. So access to this side is going to be pretty good. You can start like really either place. Access is easier here. Actually, I'm going to start like over on the left side here. Open, please. And can you rotate to 2 and 8? That's not bad. Close. Fire. And so the thing okay, keep them coming. Please.
We're going to need a few of those.
Yeah. And so, I have used all sorts of different clips. I do like the position rotatability of the resolution clips.
So you can maneuver it yourself.
Yeah, so I can make a decision on what to do. Obviously, Norma is really good at rotating clips, but I like to, as she's finding out, I like to be in control. And so often I'll use those.
And do you, just before closing, do you suction the mucosa closer?
I do. Let's rotate the same way. That's good. So I try and anchor on one side. I'm going to push the clip out to the other side. I'm going to push my scope in a little bit, push the clip forward, and suck, close. And then before I say the F word, I'm going to just check to see what I have. I'm pretty confident that this clip is in the right place. Norma was getting antsy to fire it, so fire.
Excellent. Yes. That's going to be
Yeah.
a nice approximation of that.
Yeah, so it's approximating nicely.
Yeah.
I'll take a couple more, please. So sometimes if it wasn't coming together nicely, you can start on this side now too. So we can just show what happens to the center here when we come to this side.
If the defect in the center is large, do you ever use the middle part as a?
Yeah. So I think if the defect is really large, and I don't think this is going to work, I will start in the middle and I'll use a mantis or a DAT clip to.
Jeff,
Yeah.
great work. It looks fantastic. We're just going to go back to Rob for a bit. And maybe by the end of your closure, we'll come back right back to you.
Okay, thanks, Yenny. Thanks, everyone. Close. Okay, thanks for coming back. So we're having a really good time in this room, mostly because of Norma's sense of humor, but also because we're almost done. So we're going to place the last clip here. So I'm going to just place it and then show you. And so I'm pushing my scope in here. I'm advancing the clip and then putting my hand back on the scope, suctioning the lumen, close, fire. All right. So let's see. Blad's going to tell me if he's happy with this closure. I'm a bit worried about that because he's a big closure guy.
Yeah, no, this looks like it looks beautiful. It looks
Yeah,
like a very nice.
so it came together nicely,
Yeah.
and again, we sort of predicted that we weren't going to need any of the newer type clips to close this. This is just kind of your standard everyday clips. And again, this does not need to be airtight. There was no full thickness perforation, and so I'm okay having like a little small space between these clips. And in the studies, they often had a number of millimeters between clips, and that was okay. So this type of closure is good to prevent post-DMR bleeding and prevent any delayed complications. So I'm pretty happy with that. When would you see this patient again? Rothman, please. So when are you bringing this patient back?
Yeah, so follow-up for this patient is usually anywhere between 3 to 6 months, close to about, and then at 1 year. Make sure that there's no recurrence.
Yeah, so I do SC1, so surveillance colonoscopy number 1 at the 6-month mark. And I think what we know now is that if SC1 is normal, then the chance of having any recurrence at SC2 is exceedingly low. So SC2 is possibly not needed, but we still do it. So I usually do 6 months and then at the 18-month mark after. But I'm often sending patients back to their referring doctor at that point to have further follow-up because I'm very confident that there's going to be no recurrence.
Especially after the 6 months.
Yeah, and you know, there are scoring systems to help us figure out if there's going to be a recurrence. I don't know if you use any in your day-to-day practice, but I feel like we know when we have a high risk of recurrence, and those people all be sure that they make it back at the 6-month mark. And there are lesions like this where I'm fairly more confident that went well. There was nothing residual. There was no fibrosis. There were no islands left behind. And I think the chance, subjectively, the chance of recurrence is a little bit lower. But again, still need that SC1 within the year.
Jeff and Talat.
Yeah.
Fantastic work. Perfect EMR. Very impressed. Thank you, Norma, for keeping these guys in line. We're going to move back to Rob Bashara in room 4 to look at him do his ESD.
All right. Thanks, everyone. Thank you.